Dr. Devina Nagraj. I am one of the mentors for Study EFOG. Today, I'm going to be doing a demonstration for a station for EBCOG Part 2 exam. In this, I will be the candidate, and I've also got a role player with me who will also act as my examiner. And we will do a demonstration for performing a station. So, the topic for today is going to be a teaching station. So I've got the instructions with me, and there will be 1 minute of reading time, which will be followed by 11 minutes of performance time, in which I will be acting like the exam candidate. And after that, we will have feedback. So I have my examiner with me who will be giving me feedback on the performance. And yeah, that's how today's session is going to be. So, are we ready to start? Let's go then. And I've got the scenario in front of me. So it says you have 1 minute of reading time and 1 minute and the same time to prepare yourself as you before you enter the station. So you are the senior specialist on duty of labor ward, and you've got a newly joined junior doctor who is here to learn obstetric examinations. You will be assessed on the teaching aspects to your junior. You have 11 minutes. Okay. So I will start the session now. Okay. So let's start. Um, Hello. Hi. I'm Devina. I'm one of the registrars today. May I please know your name?
Hello, Dr. Devina. I am Priya. I've just joined here newly in the department.
Okay, Priya. How are you doing? How are you liking here in the department?
Well, thanks for asking, Dr. Devina. It's been great, but I'm also a little bit worried about how to go about this.
Mhm,
Things are all quite new, and I'm really looking forward to learn.
mhm. Okay. Okay. Can you tell me a little bit more about what you're worried?
Well, I just happened to be in the antenatal clinic yesterday, and the consultant was just saying the baby is in this position and all that, and I was just clueless. I was not able to understand. Just that the tummy looks big, and I'm not able to make out anything. So I'm really
Yeah.
worried about that, and I would like to know more.
Okay, yeah, I can see that you are quite a keen observant when you saw that what your consultants were doing about the examination. So don't worry, today we'll learn a little bit more about this. Okay, so what we'll do is I've got a little mannequin here with me, so I will talk you through the basic steps of examination, and we will only stick to the obstetric examination, which is just the obstetric examination, and not go into the general examination and other details. So I will show and demonstrate it to you, and you can do it with me. And then, if you have any questions, then we can go through them together. What do you think about that? Is that okay?
Well, that sounds like a plan, and I'm totally into it. Thank you
Okay.
so much.
So let's start. So first of all, before doing any examination, you must always make sure that the woman's happy for you to examine her. So you make sure we have consent. You can verbally ask her, and you can tell her, okay, I'm going to do a tummy examination, and we need to ask her to lie on the couch. And we sometimes, when in the advanced gestation, we need to make sure that she is on a left tilt of 15 degrees, so that there isn't much pressure on the vena cava if she's lying flat. Are you with me so far?
Yes, yes, I do understand. Yes.
So we will ask her to expose. So we can consider that this is the patient that's lying, that's her abdomen, in which we will be doing our examination. We always stand on the right hand side of the patient. And let's start with the inspection. Before going ahead, can I just check what do you do in advanced gestation? How will you ask the patient to lie?
Slightly to the left, a bit of left tilt.
Yeah, yeah, that's right. That's right. Very good. So let's go on with the examination. In this, we'll first talk about inspection. So we look at the abdomen. Is it a longitudinal lie, or is it a transverse lie, or is it an oblique lie? You can tell it by the look at the bump of the lady on or
Okay.
of the baby, which tells you if the baby is lying longitudinally, obliquely, or
Okay.
diagonally. Okay.
Right. Yes.
So in this instance, I've just have this so we can we will take that the baby is lying longitudinally, so like this. Okay. Other thing we are doing in inspection is we are seeing for any scar marks of cesarean section or any other surgeries. That gives us a little bit more idea about if she's had any previous abdominal surgeries and then she ends up in a cesarean section, then we can make those note of those things. Also, we look at the linea nigra, which is the central dark line, and the stretch marks, which is also known as stria gravidarum. So we look for those. Those are signs of, and if there are any other abnormal discolorations or any other marks or anything else, then we make a note of all those. Are you with me so far?
Yes, yes, I understand.
Sometimes we can also see baby movements. Of course, it depends on how, if some a very lean and thin woman and an advanced gestation and the baby moves or kicks. Sometimes we can see that, but it's not very common, and you might not always appreciate it. Okay.
Okay.
Any questions so far, Priya?
No, no, this is fine.
Yeah. Okay. So let's move on to palpation. So palpation is the step where we will try to, which includes the symphysiofundal height, and we also include grips to check how the baby is lying in the uterus.
Okay.
Symphysiofundal height, as the name suggests, measures from the symphysis pubis to the fundus, and that tells us gestational age of the woman. It should coincide with the gestational age of the woman. So we take a tape, feel for the symphysis, we put the tape on the symphysis pubis, and we go up to where we can feel the fundus is. So feeling the fundus in a border, you can uh, put press and check till where you can feel the fundus, and that's where you measure. Okay.
Okay. Okay. All right.
This is the model where we can try. You can come with me. I can show you. So this is where you,
Thank you for that.
yeah. So this is where you put and yeah, measure like this. Okay. So then
Okay.
measures, for example, 36 centimeters. So it should correspond to 36 weeks of gestation. Do you?
Okay. Yes, I understand.
Okay. So let's so that's one thing. Then the other thing that we will do is we do the grips. So the grips means that we are going to try and feel different body parts of the baby to ascertain lying in the abdomen. So just
Okay.
this is the head end of the patient. Okay.
Mhm.
To start with the fundal grip. So fundal grip,
Okay.
the fundus of the uterus is. Okay. So I'm taking my
Mhm.
two, trying to feel what part I can feel at the fundus. You can start with the fundus or you can start with the pelvic grip. It's okay to do it either. Okay. You
All
want
right.
want to come on this side and try? Yeah.
Yes, definitely. I would love to.
Yeah. Then the second grip. So usually, what we feel, if the baby is head down, which is cephalic, you should feel a round, soft part, which is the bum of the baby. And if it is the bum of the baby that is down, which is breech position, then you can feel a hard, palatable head on this.
Okay. Understood.
Yeah. Let's come to the lateral grips. So on lateral grips is on both the sides of the abdomen. So this we are doing to check which side the baby's back is. Okay. So the
Okay.
back will be flat and broad, uniform surface. And the other side where the limbs might be will be knobby, small knobby feelings you will feel where the limbs are. Are you with me?
Okay.
Yeah.
Yes. Yes.
Want to come and
Yeah.
try?
Yes, definitely. I would love to. Thank you.
Any questions so far, Priya?
No, this is fine.
Okay.
Sometimes I really get confused with this knobby structures. Like, you think we really need to identify whether it is the foot or hand, or it is just okay to say limbs?
Yeah, it's okay to say limb. It's very difficult to identify hand and feet. Again, it
Okay.
also on the build of the lady. Sometimes there's a large abdominal fat, so it's not very the other parts are not very well appreciated. So it's okay to say limb buds. You don't have to mention hands or feet in this in this. Okay,
All right.
yeah, and then we come to
Understood.
pelvic grip. This now we are in the pelvis, so we take two hands and we try to feel what structure we can feel. Is it a round, palatable head or soft round of the baby? Okay.
Okay. Okay. All right.
And
Yes.
And then there is another grip, which is pollic grip, which is done by one hand. So
Mm-hmm.
you should make sure that you don't cause too much pain to the patient. So always keep looking at her face to look for any signs of comfort, or keep asking her about, okay, what if she tell her that she will make you aware if she's feeling any pain. Okay.
Okay, okay, great.
In this grip, we try to palpate the head and see if it is fixed in the pelvis, or if it is okay. So if we are
Okay.
to feel the head of the baby all
Mm-hmm.
the way through, which we call as 5 by 5, then
Okay.
that the head is above the pelvis. Okay.
Mm-hmm. Okay.
Will get more confident and comfortable as the more number of times you perform these
Okay.
examinations.
Okay, sure.
Yeah. So this is the four grips. Now, are you okay with all this so far?
Yeah, yeah. I think, probably I just need a more of practice on this, but you're really doing good. Thank you.
Okay, okay. So now let us move on to listening to the fetal heart. That is also an important part of the examination. So sometimes
Okay.
Pinard's stethoscope, or you have your normal stethoscope, and sometimes you have electronic Doppler machine. So it just depends you have got. You have to use it to listen to the fetal heart. Now, if we have found that the head is down and we have felt that, for example, back is on this side, we will try to listen on this side for the fetal heart. Okay.
Mm-hmm.
And you try it, if it's a Pinard scope or if it's stethoscope, you just put the it flat against
Mm.
the abdomen and you try to hear for the fetal heart sound. You can put
Okay.
other hand on her pulse so that you don't sound. If it's coinciding with her pulse, it means that that's not the fetal heart, that's maternal. So we must make sure that we
Okay.
between fetal heart and maternal. Okay,
Okay. Mm-hmm. Yes.
basic. And what we can probably do is I can give you some reading in material and some videos to look on the YouTube. And
Mm-hmm.
when I clinic next, then we can do some examinations together. How does it sound?
Okay. Yeah, absolutely fine for me. Thank you so much for inviting me.
Any questions you've got, or anything that you want me to explain further?
No, I think you are really good. You explained many things, and you're maintaining the pace well. I just think I'll have to go and read about it a bit more, and I will certainly come back with my queries.
Yeah, 100%. Yeah, sure. So I'm around. You can contact me whenever, and whenever we are together, definitely we'll do some examinations.
Yeah,
Okay.
sure. Thank you.
Okay. So thank you for your time today, Priya.
Thank you.
Okay. Thank you. So this concludes the station, and now we'll wait for feedback.
So, good evening, everyone. So, Dr. Devina, at the outset, it was a very, very well done station, I should say. You were perfect. Your introduction was good. You set the agenda right. You looked for the background understanding, and you went on step by step explanation, and you gave a very good conclusion also. Some points that I feel, probably that we can look up is when you start off with the procedure, you did mention about, the agenda setting, taking the consent and all that, and positioning and all that. However, the patient's privacy, to take her to a separate room with good lighting and ensure that her bladder is empty, because you are going to do the pelvic grip and it shouldn't be an hindrance. And sometimes giving you the falsely an elevated bladder will not give you a proper symphysiofundal height measurement, right? So these were some points I think I should have, you could have actually looked into, because that's what my marking scheme also says in my paper. Because for exams in EBCOG, we do have the marking schemes that are given to the examiners, right? So the examiners generally stick on to what has been given there. So these were some points there. And again, apart from that, you are standing on the right side of the patient and you're ensuring the displacement of the uterus is corrected. You put her into the left lateral. These were all very good points that you had covered everything. And then you went on with explaining all the maneuvers, right from inspection to palpation and the auscultation. you know, since this is a teaching task and you have a junior, you can include terms like Leopold's maneuver. So just to, give them some fancy names in between, or use some guideline references in between if appropriate, so that the teaching enhances. You get add-on points on your teaching. And also, we did talk about the baby position, the baby movements, the scar, and everything. We talked about FHS, but a bit of mention about the Liker, the amniotic fluid also, whether clinically it appears good or less, something about that can also be mentioned. I think, these were some
Mm,
additional points that, as per the marking scheme, that were missing.
mm.
But I would say this is a definitely pass. You have definitely passed the station. But these were some additional points that I wanted to tell. Being as the role player with you, we need to understand that in EBCOG, the role player also has some marks to be given to the candidate. From the role player point of view, you were very empathetic, you are very understanding, you're involving the role player completely into the station. So these are very, very good points. There is no negative comments from the role player point as such. Overall, a very good performance, I should say.
Okay. Thank you. Thank you for your feedback, Dr. Priya.
Thank you, Dr. Devina.
Thank you. So,
We
this
can
was
go through the slides. Can just go through the slides once.
okay. So, these are the role player instructions. We'd go to the next slide. Yeah, so as you can see in the inspection in obstetric exam, these are the basic points that you should be covering. Other than the feedback that Dr. Priya has given. So the in inspection, we should see for abdominal shape. We can see fetal movements. We can see for any surgical scars, the linea nigra, stria gravidarum, and stria albicans. These are the stretch marks that we look for in the inspection. Next slide, please. In palpation, we again try to palpate the fundus where the fundus is, and try to ascertain the gestational age depending on the where the fundus is. So this is a rough guide on where how the fundus grows with a different gestational age. But we do rely on the fundal height that we measure to get the exact uh, findings. Next slide, please. Yeah, so these are the different Leopold's maneuver or grips as we discussed, the fundal grip, the lateral grip, the pelvic grip, and the pollex grip. So this picture shows you how you do these grips. And of course, we did discuss about what things we're supposed to feel while doing the grips. And next slide, please. Engagements. So again, the fetal head is divided into one-fifths, and depending on how much we can feel, we decide if it is engaged. So if we are able to feel the entire head in the abdomen, which means it's 5 by 5 palpable, and if we are not able to feel the head at all, then it is 0 by 5 palpable. So depending on how much we are able to feel the head, we tell it's 1/5 palpable, 2/5 palpable, so on and so forth.
All right.
Next. Uh, Fundal height. So that is, as we've discussed on the station, we have to locate the fundus, which is the firm, the upper border of the bump. And once we have identified the fundus, we measure with a measuring tape, and we measure the distance between the symphysis pubis and the fundus. And gestational age can be anywhere within plus minus 2 centimeters of the symphysiofundal height, which is, and if it is more than or less than this, then we have to consider, do we need further investigations, and are we suspecting a growth restricted baby, are we suspecting oligohydramnios and things like that. Next slide. Fetal heartbeat, FHS, we should listen to the fetal heartbeat. Again, depending on the position, we will use, are there pinards Pinard stethoscope or normal stethoscope or a Doppler machine, and always maintain always check patient's pulse, and if it is coinciding, then try to look for fetal heart, and keep monitoring the maternal pulse. Again, make sure the patient's not too uncomfortable in the process. Okay, next slide. This is brief marking scheme where there are marks for communication, your technical skills, your teaching skills, and of course the marks from the role player. And we've already discussed the marking. Okay.
Thank you, Dr. Devina.
Thank you, Dr. Priya, and thank you all, and wish you all a very best of luck for your preparation and for your upcoming EPCOG exams. All the best. Thank you so much. Take care. Bye.